Okay, good morning. Are you all seeing my screen? Good morning.
Good morning. Yes, we're seeing your screen.
Okay, I don't know if I was muted when I was talking just now. I was apologizing for coming late because I had difficulty getting a park. And I'll also state that I may have to leave because I'm blocking someone. So I may have to break my lecture for a few minutes to go and move my car if they're ready to leave prior to my finishing the lecture. Let's put this on. Okay. All right. So good morning again. My name is Professor Helen Trotman Edwards. As I had noted in the last lecture, I am from the Department of Child and Adolescent Health in the University of the West Indies, but I also work at the University Hospital of the West Indies, and I'm a neonatologist there. I'm just going to show my face for those who don't know me. It's just a quick face. Right, I'm a neonatologist, so I look after the babies, the first 28 days of life. Now I'm just going to recap, if I can only get this to move. Okay, so we are doing the child health module of the maternal and child health. Well, the child health portion, I should say, of the maternal and child health module. And we were looking at, in our last lecture, we were looking at the sustainable development goals, that which we hope to achieve by 2030. And that is to end preventable deaths of newborns and children under 5 years of age. And what we are hoping to do is to reduce neonatal mortality to at least as low as 12,000 live births, and also to reduce our under 5 mortality to at least as low as 25 per thousand live births. Oh dear, what is going on? All right, for some reason, my screen is refusing to move. I don't know why I have this nonsense. I don't want this. What's this? See if we can get it to move. No. Okay, fine. All right. We had said that the reason that we look at the under 5 mortality rate in child health, because it is a good barometer of your child health care in your country. We had said that reducing the under 5 mortality rate requires political will, sound strategies, and adequate resources. We said that for further improvement in child survival, it requires concerted efforts to reduce socioeconomic disparities. And we had also noted that maternal, newborn, and child survival must remain at the heart of the post-25 global development agenda. We had said that the under 5 mortality rate was a good gauge of child health. And we had said that for now, for us in Jamaica, we could look at all of this with a post-Melissa lens. And so why is the under 5 mortality a good gauge? Well, it's known to be the result of a wide variety of inputs. We had said the nutritional status and the health knowledge of mothers. We can see why the nutritional status of a mother is important, because if you want healthy children or healthy babies, you have to start with the mother. What is her nutritional status coming into pregnancy, throughout pregnancy, and at the perinatal period, birth, delivery, and after. So the nutritional status of the mother is important, because if you want healthy children, you need healthy mothers. If you want healthy adolescents, you need healthy children. If you want healthy adults, you need healthy adolescents. And we know that the goal really is that you're going to have a healthy and productive human resource pool, right? health knowledge of mummies are important because that is going to determine how is that mother going to pick up symptoms that her child may be having, and to know when to seek health care, and also to understand the importance of what we call well baby care, which we are going to go through, which is very important in our looking at child health. The level of immunization we had spoken about, we had said oral rehydration therapy was one of the single most important therapies in childhood, and it has significantly reduced mortality and morbidity from gastroenteritis. Goes without saying the availability of maternal and child health services, including our prenatal care, income and food availability in the family, the availability of safe drinking water and basic sanitation, and the overall safety of the child's environment. We said we need to measure what we treasure. We need sustainable data for sustainable development. And we said only by counting the uncounted can we reach the unreached. And we saw that, we have seen that with Post Melissa, where there are certain areas that, were isolated, were cut off, we couldn't reach. You didn't know how many people were there, how many people had died, So we have to count, only by counting the uncounted can we reach the unreached. So data as the basis of evidence-based decision-making and accountability are a crucial pillar of the post-2015 development agenda. What was the current? We had gone through the current situation between 1990 to 2022. The global under 5 mortality rate decreased by 60%, and the global neonatal mortality rate decreased by 53%. Remember those interplays we had gone through? So under 5 mortality rate is the number of children who die between birth and their 5th birthday per 1,000 live births. We had said that 75% of the under 5 mortality rate is accounted for by your infant mortality rate. Right? The infant mortality rate is the number of children who die between birth and 1 year of life per 1,000 live births. And we are saying that for your under 5 mortality rate, 75% of that occurs 1 year and younger. Then when we had looked at the infant mortality rate, we had said that the neonatal mortality rate accounts for about 75% of your infant mortality rate. So babies who die within the first year of life, 75% of them will die within the first 28 days of life. So remember, our neonatal mortality rate is the number of children who die between birth and 28 days per 1,000 live births. And then when we had looked at neonatal mortality rate, we had recognized that about 75 or 70% of children who will die in the neonatal period will die within your first week of life. And we call that the early neonatal mortality rate, which is the number of children who die between birth and 7 days per 1,000 live births. And we had said for that early neonatal mortality rate, 50% of the babies who die in the first 7 days of life die within the first 24 hours of life. So that we have said the first 48 hours of a baby's life is crucial. Right? So we had looked at that interplay. We had said although both the under 5 mortality rate and neonatal mortality rate had decreased, the degree by which the under 5 mortality rate decreased was greater than the neonatal mortality rate. And so now the neonatal mortality rate occupies a greater percentage of your under 5 mortality rate. As of 2022, just one more thing, we had looked at our perinatal mortality rate. We had said that's the only rate that it's not per 1,000 live births, it's per 1,000 deliveries. And that's because it's the number of stillbirths plus the number of babies who die within the first 7 days of life per 1,000 deliveries. And we said that the perinatal mortality rate is where we see the interplay of maternal and child health, because the stillbirth rate is a gauge of your antenatal care, right, and your care of your woman, while the early neonatal mortality rate is a gauge of the care of the babies. Right? As of 2022, 134 of 200 countries analyzed have achieved the Sustainable Development Goal for the under 5 mortality rate target. And remember that the Caribbean and Latin America in 2022, we have achieved that, but we are saying that's a minimum. And so we are not sitting on our laurels, we are pushing on. All right, so 7 countries are on track to achieve the target by 2030, while 59 will need to accelerate progress to meet the target by 2030. We had pointed out that sub-Saharan Africa and Southeast Asia, which is India, Bangladesh, Sri Lanka, Pakistan, Bhutan, that area, those 2 areas would need an accelerated rate of decrease of the under 5 mortality rate if they are to achieve, if globally we are to achieve that 2030 target of at least 25 per thousand, your under 5 mortality rate of at least 25 per thousand live births. As of 2022, 126 countries have reached the Sustainable Developmental Goal for the neonatal mortality rate target, with 10 on track, leaving 64 at risk of missing the target. So if current trends continue, 35 million under 5 deaths are projected to occur between 2022 and 2030. Almost half of them are projected to occur during the neonatal period, 60% in sub-Saharan Africa and 24% in Southern Asia. Okay, so that's what we had done. That's recapping our first lectures. Let's move forward. And as we said, we need sustainable data for sustainable development. So we're going to look at some vital statistics. This is Jamaica coming out of Ministry of Health and Wellness. And I have not been able to find any updated since these figures, right? But in 2017, there were total live births of 33,979, and we had about a 9.6% low birth weight, which is babies who weigh less than 2.5 kilograms. The perinatal mortality rate for Jamaica, that's 2017 January to March, was 25.9 per thousand deliveries. The neonatal mortality rate quoted for 2016 was 12 per thousand live births. The infant mortality rate was 15.5 per thousand live births, and the under 5 mortality rate was 16.4 per thousand live births. As I said, no further, but based on this, but I do know that the neonatal mortality rate of Jamaica is not at 12, it's at about 14 per thousand live births. So we have not quite achieved the Sustainable Developmental Goal as yet. Okay, what coming out of what we have been speaking, what would be the priorities for child health? We would first look at the Caribbean and then we will come, so we look at the Caribbean. So based on what we have said, certainly perinatal care is very important because if we had to bring down, so remember we had said the under 5 mortality rate accounts for 70% of mortality, where mortality occurs in childhood. We said that we were looking at childhood, the WHO and PAHO and UNICEF say childhood goes up until 24. So looking at the deaths between birth and 24 years, 70% of those will occur under 5 years, right? And when we went through, we see that if we want to bring down that under 5 mortality rate, we have to bring down our infant mortality rate. If we want to bring down our infant mortality rate, we have to bring down our neonatal mortality rate. And if we want to bring down that neonatal mortality rate, we need to bring down our early neonatal mortality rate, the first 7 days, which is part of your perinatal, right? And therefore, that's why we are saying perinatal care. We'll go into it in more detail, but certainly priorities have to be perinatal care. Early childhood development, looking at domestic violence, interpersonal violence. Remember, we had spoken about when we were looking at the child, the environment in which the child grows up. We have to look at child abuse, childhood disability, nutritional disorders, HIV, AIDS, and after COVID, I had added mental health post COVID-19. After last year, I'm now adding for Jamaica, certainly mental health post Hurricane Melissa. Okay, so what are some of the solutions the Caribbean has looked in terms of perinatal care? Well, certainly registration of births and deaths. Remember, you have to count the uncounting to reach the unreached. If we do not know how many births we have or how many babies die, then we do not know where we are. So registration of births and deaths. The use of institutions as registration centers for all vital events occurring there. Again, I may be dating myself, but certainly when I had my children, registration didn't happen at the hospital. You used to get this little red, this slip of paper with red writing, and we had to go to the registrar general department, which at that time isn't where it is now. It was in Spanish Town, in one of those old colonial buildings. It used to be crowded. Registering your baby took a day, literally. You went there, you sat on benches, and you moved down as a name is called. You move down, you move down. Now, just imagine a woman post delivery, right? Because you want to go and register your baby. So you're in the postpartum period, post delivery. You're going to this place where you have to spend a day. So what used to happen there, a lot of people then used to register births and deaths. And this was seen in 1983, and we'll come to it, when you had the National Perinatal Survey. They recognized how many births and deaths were not registered. And so coming out of that survey was a recommendation that you needed to bring registration right to where the people are, meet them where they are. And that's just how now you'd have departments in each of the hospitals of the Registrar General Department. And not only that is the department there, you have the administrative staff that go to the postnatal ward. So they go to the bedside of that mother and they register. They will register your birth right at the bedside. And once the father is there, because prior to that, there was a whole problem if the couple wasn't married, the father had to come along or whatever. So if you catch the father at the bedside, he can say, yes, he agrees that he's the father, whatever, and his name is put on it. So one of the things is using institutions, bringing it right, so they don't have to get up and go to the registrar department, general's department. It's being done at the bedside. Training of doctors and midwives in the correct completion of death certificates. This is something that we are really working on because, and I'm going to say this, a lot of times the death certificates, the work of writing that up is left to junior staff, sometimes the intern, right? And therefore, sometimes those death certificates aren't, I would say, accurately filled out. So again, right, if we want to get to the source of problem, we need data. So for every death, we need to know cause of death. Has there been an autopsy? What are the findings, right? So train doctors and midwives in correct completion of death certificates. Incorporate training and completion of death certificates in medical curriculum and midwifery training programs. Again, when I was in medical school, we had no class on how to fill out a death certificate. Is when you start working, your senior person to you may walk you through the first one, and then after that, you are filling it out. So again, incorporating that sort of training. Improvement in antenatal care. So again, a lot of the things we do today came out of that 1983 National Perinatal Survey. Right? I don't know if, again, I may be dating myself, and a lot of y'all are so young you won't even know, but a lot of the things that we do, for instance, doing that VDRL on every pregnant woman, doing that hemoglobin or sickle test or hemoglobin electrophoresis, um, that came out of that 1983 survey, because what they found was that a lot of women who had syphilis, who were VDR positive, were not being picked up, and so the babies were being born, and then we had syphilis in the newborn. And again, as an intern, I remember working at Bustamante, and I mean, we always had 2 or 3 babies who were having symptoms of congenital syphilis. That is something that we hardly see now. Although I know the ministry has said they have seen a slight increase in the numbers of the positive women, but because the women are screened, and if they are positive, they are treated. And now they are not only screened in the first trimester, but they are also screened in the third trimester and treated. So that is something that's coming out of that perinatal survey. And again, a lot of the mothers did not know their sickle status, right? And they don't know their partner's sickle status. So you would have it only when the baby is born with sickle cell disease. So a lot of what we do now, improvements in antenatal care. Ideally, what we want, right, is that a woman should actually present to her obstetrician, to the clinic, prior to becoming pregnant. That's the ideal, right? So that she can be counseled. So we can look at things like, what is her weight, right? Is she coming into pregnancy obese? What is her diabetes status, right? Is she having difficulties, controlling her blood glucose level? What is her blood pressure like? We can do tests. What is her hepatitis B status, etc., etc. And there can be counseling. So, for instance, for women who may have type 1 diabetes, we know that they should go into pregnancy with their glucose controlled, because if it's not controlled, you can have it affecting organogenesis, and you can have congenital anomalies, right? We can start our folic acid early to help prevent spinal cord um, problems. So ideally, what we want, a woman is presented from the time she is considering. We would want that every pregnancy is planned. We know that that is utopia, but that every pregnancy is planned, so the woman is coming into pregnancy with in the best health. We special attention to high risk groups. So again, women who are at high risk or who have high risk pregnancy should be seen in specialized clinics, right? And we have that. We have our high risk clinics where women who are hypertensive, etc., obese, etc., who have had previous problems in pregnancies, they are being seen in the high risk clinics. Improve access to tertiary care. What do we mean by that? There are some babies. So if you have a woman who is in prem labor, and she's going to deliver, that woman really should deliver in a facility that can care for the premature infant. So we should have improved access to tertiary level. So we're not saying that every hospital should be able to manage a premature infant, but we are saying there should be easy access for transfer. So if the woman is at a facility that cannot handle, we should have transfer. Ideally, we want in utero transfer. The best way, trust me, guys, the best way to transfer a baby is in utero. It makes such a difference, right? So the best way for high risk women, if their babies need to be delivered at a tertiary hospital, is in utero transfer. As best as possible, prevention of premature birth. Remember when we were looking at our our neonatal mortality, we said that there were three big things: prematurity, asphyxia or lack of oxygen, and infection. So prematurity really accounts. So, like for instance, at the university hospital, a very low birth weight infant, which is a baby less than 1,500 grams, accounts for about 3% of our birth cohort. But it accounts for about 50 something or 63% of our mortality. So if we can, that prevention of premature birth, which again, if the women come to antenatal care, they are monitored, etc. If we can prevent, although in reality, we do know it is very difficult to totally prevent premature birth. Fetal monitoring during labor, and appropriate use of cesarean section. So I'm not here advocating that every woman should be delivered by cesarean section. We are saying appropriate and judicious use of cesarean section.
I have a question,
Prevention.
Dr. Shotman.
Sure.
I have a question.
Yes, go on.
Earlier you mentioned when you were intern, you saw a lot of cases of congenital syphilis at
Mm-hmm.
Buster. Could
Mm-hmm.
you like give us some ideas of some of the symptoms the babies would, some of the signs that you'll pick up for this congenital syphilis? I don't think I've seen it
Well,
so far.
I was going to say to you, you really want to date me now? Because if I tell you when I was an intern, that will be dating me. But I will tell you that that was um, in the 90s, right? And so what the babies will come in with, they come in with what we call pseudo paralysis, right? They don't want to move their limbs. Their limbs are extremely tender because you get a periosteal reaction in the long bones, right? So when you touch them, they cry. So they are very cranky. They are crying. If you pick them up, they scream, right? So they have, and they're not moving the limbs. So they have pseudo paralysis. So that's one thing you can get. They can get something called snuffles. So they have a persistent runny nose from very early. It's called snuffles, right? Uh, they can get hepatosplenomegaly. They can be anemia. The hemoglobin is down. They can have skin rashes, right? But the classic one is a rash of the palms and soles, right? So they get these brown spots. Once you see that classic palms and sole rash, right? That is something you have to consider congenital syphilis. Uh, those are the big ones. They can have, other ones, but that is what you're going to see. This cranky baby, they don't want to move their limbs. They're crying. You pick them up and they scream because the limbs are very painful. And when you do that, we usually do a skeletal survey. You see the periosteal thickening and raising of the periosteal. That's the outer layer of the bone. And it's very painful. So that's the classic one, the runny nose, the snuffles. Sorry about that. Hold on. Give me 1 minute. Sorry. Okay, sorry about that. As I was saying, so they're very cranky, hepatosplenomegaly, anemia, skin rashes. You can have it on the body, but the classic one is the palms and soles. Yeah, They can have the CSF, but those are lab findings. But that's a classic thing. Yes? Hello? Anyone hearing me?
Yeah, we're hearing Doc.
Oh, okay. All right. Did I answer the question? Okay. I will continue. So, right. So, prevention of vertical transmission of infections, right? So, we spoke about the congenital syphilis. So, now, as we say, we screen the woman, right? When they come in the first trimester, and we also screen in the third, and we will treat appropriately. You know that we have our prevention, maternal to child, the prevention of HIV, maternal to child transmission, right? You know that we are now giving Hep B vaccine at birth, and that is in an attempt for if we do not know whether the mother is hepatitis B positive, that giving the vaccine has been shown to help prevent transmission to the baby. And that is why we now give that Hep B at birth. Improve facilities for neonatal resuscitation. So it's what the ideal should be that at every delivery you have someone who is versed in neonatal resuscitation. Now, it doesn't necessarily mean it's someone who's versed in being able to intubate a baby, etc. That would be ideal. So the ideal thing is that at every delivery you have someone who can intubate and a baby, but we can do adequate basic resuscitation by bag and mask ventilation. So really and truly, at every delivery, you should have someone who can do bag and mask ventilation and who can do cardiac compression, right? And you can keep a baby going until the person who has the skill of intubating, etc., arrives, right? But we have to look at our neonatal resuscitation, have adequate training in neonatal resuscitation, improve care of sick newborn infants, right? So again, remember, I think I pointed out that we advocate that all babies be delivered in a health care facility. And one of those reasons is that we cannot predict. If we could predict who are the newborns who are going to give us trouble, life would be easy. But we cannot always predict. And therefore, we are saying babies should be born in a unit or somewhere where at least can start basic care, right? Even if that baby then has to be transferred to another center. And of course, adequate follow-up of neonates after discharge from the hospital. We also advocate that every neonate should have a full examination prior to leaving hospital. So that, a pediatrician or pediatric resident or somebody with pediatric, every newborn really and truly before leaving hospital should be examined. So we do not miss, we should not have a baby going home and coming back with abdominal distension and vomiting because there's anal atresia. That is something that's supposed to be picked up prior to the baby leaving the hospital. We shouldn't have babies coming back because certain things were missed. Although in saying so, right, murmurs you don't have to have a cardiac murmur on the first or second or third day of life. So a baby can be examined and there's no murmur, but then they come back later on. But we are saying that and ideally again, every baby really should have some sort of hearing screening before going home. We do not have that available, but that is ideal. Also, we need to look out for neonatal jaundice, right? And if that baby is having neonatal jaundice, we need to do a bilirubin level, and we need to review that baby in a timely manner. So adequate follow-up of neonates after discharge from hospital. So here's where your domiciliary service is very useful. I know since COVID, unfortunately, the university hospital, we haven't been able to resuscitate our domiciliary service. But that was really a very important service because it went into the community, went to the mothers, right? Made sure they were okay, look at how they were breastfeeding, are they having sore nipples, how is the baby feeding, is the baby jaundice, etc. And if they pick up anything, just send the mother, say, go to the hospital, right? So adequate follow-up of neonates after discharge from the hospital. Okay, so we had perinatal morbidity, right? We had said the mortality was the preterm infant asphyxia and infections. But morbidity, right? We still have the asphyxia being there, complications. So the baby hasn't died, but they have morbidity from the underlying conditions. So the asphyxia, the complications of prematurity, the low birth weight, and of course the hyperbilirubinemia or the jaundice. Okay, so just looking in the Caribbean, neonatal mortality, right? And again, I am just giving figures that are available, and I want to push that we need updated data because to be able to what is going on now, right? So newborn deaths account for the major portion of infant mortality in the Caribbean. In Jamaica, newborn deaths account for about 77% of infant mortality. All right, so I had been speaking about the perinatal morbidity and mortality survey. So this is about what, 35 years ago or more, right? This was done in 1986 to 1987. So what we're looking at here is about 38 years. But look at some of the things. Remember, I was telling you that some of the things we do today is based on what we got from that morbidity and mortality survey. 56% of the recorded neonatal deaths occurred in the first day of life. That's like what I told you globally, right? 89% in the first 7 days of life. Again, commonest cause of death was immaturity, which is prematurity, 39%, and asphyxia-related deaths, 35%. That's lack of oxygen, right? At that time, the neonatal mortality rate was 17.9 per 1,000 live births. The early neonatal mortality rate, that's the first 7 days of life, was 16 per 1,000 live births. And well, the late was 1.9. What were the major determinants of neonatal mortality? Young maternal age, prematurity, intrapartum asphyxia, and twin gestation. So that's coming out of the 1986-1987 perinatal survey. Okay, the next survey that we had after that was the 2011 JA Kids study. So this study aimed to determine the mortality in a Jamaican birth cohort over a 3-month period. So data on the outcome of 87.5% of all births. So this study didn't capture all births. The perinatal study of 1983 did, but this study used 87.5% of all births in Jamaica between July and September 2011, and that was used to ascertain neonatal mortality trends and determinants. Okay, there were 9,650 live births, 144 neonatal deaths, which gave a neonatal mortality rate of 14.9 per 1,000. 121, 84% of the deaths occurred within the first 7 days of life. See how much? 84% of our neonatal mortality rate is in the first 7 days of life. And there was an early neonatal mortality rate of 12.5 per 1,000 live births and a late mortality rate of 2.38 per 1,000. 48% of the deaths occurred within the first 24 hours. That's in keeping with the global. Remember, I said 50% occurs within the first 24 hours. 26% of those who died within the first 24 hours, 26% died prior to being admitted to a neonatal unit, so approximately within 2 hours of life. So 26% of the neonatal mortality is happening perinatally around the time of delivery. and maternal age less than 15 years, decreasing birth weight, prematurity, male gender, and multiple gestation were associated with an increased risk of mortality. Right? So, what we are seeing in Jamaica is more or less in keeping with what we see globally.
Professor,
Yes?
yes, question. Good morning. I
Morning.
remember my mother telling me that boys die quicker than girls. And then I
Uh-huh.
heard you mention that being a male is something significant. So what is it about being male that makes the males more susceptible to early death?
If we knew, but it is something we see. It is something we see that the male infants do have a higher neonatal mortality rate. This is not scientific now. What I'm going to say, it's not scientific. But what I've seen written is that more male babies are conceived, and with more dying, it evens out because you at the end of the time you have almost equal in gender. I'm saying it's not scientific, so please don't go quoting me, but that I've seen that more male babies are conceived, but more of them die, and that's how you have an evening out of your gender balance. But it's not scientific. Please don't write that in any essay or any answer to any question.
No
But
problem.
we do notice that male gender, yes, you have an increased risk of mortality. And we see it over and over again. If I have two 28-weeker babies and I have a male and female, I'll bet on the female to survive. And that is what we see. Why that happens, I don't know. And I wouldn't say anything because I'm sure we have male students, don't we? I'm not hearing the males. What are y'all saying? No male voice?
I morning, Doc. Yes, I think like you said, it's perhaps a matter of the difference in frequency of male births versus female births, but
Yeah.
no,
Well, we
not
really don't
scientific.
know.
So we'll
Not
work with what you
scientific.
say.
Not scientific whatsoever. You can say scientifically that what we see is that we do have increased being the male gender is at increased risk of dying in the neonatal period. But why, we do not know. But it is something we see.
Morning, Doc.
Yeah.
Maybe the girls are just stronger.
Well, I'm not saying that, that is not scientific at all. But
Morning, Professor.
yes,
I,
more.
I I can truly agree with you because over 25 years in nursing and my experience working in the neonatal unit, I've realized that majority of our deaths, especially in the premature infants,
Mhm.
neonates, is always males. I've realized it too.
Yeah, I'm telling you, if I have two tiny babies, two 28-weekers, a male and a female, I will, I bet on the female. I bet on the female to survive. But
Doc-
I don't know why.
Dr. Chapman Edwards.
Yes,
Hi, good morning. I've heard us
morning.
say that it's because males do poorly when they get PPHN or persistent pulmonary hypertension of the newborn. Do you think that would have a play into it?
Well, I don't know because the truth of the matter, the male doing worse with persistent pulmonary hypertension in newborn is really a proxy for the males doing worse rather than it's because of PPHN. It is known, and I mean, it's not just to say in Jamaica or whatever. If you look at outcome of premature infants and that sort of thing, you would see that the male, in many studies, they say male gender puts you at higher risk of not surviving. But no one is able to say why. That's the truth. No one is able to say why.
Prof.
Hold 1 minute. I see something. Remember my car. Give me a minute.
No, sir. I don't like it here, I'm not. No, you walk like it. Like it broke up.
Vanessa,
Oh,
you
pull up your
mentioned
pants.
Vanessa, Vanessa,
Vanessa,
your
we're hearing your
mic.
conversation.
Okay, sorry about that. Oh, to run to get the space. Oh boy. All right. Where we reached. Right. So we were talking about male gender, and I say it's not just in Jamaica. It's it's something we see, can't explain. All
Prof,
right. So yes. Mhm.
if I may offer some information, one
Sure.
train of thought to that is that the Y chromosome is very fragile.
Mm-hmm.
And so they think that that's perhaps why the male babies are not as robust after birth. And additionally, some studies in the US have found that there is a sort of selection that occurs during stressful periods. More female babies are born, as in the fathers will donate the X chromosome preferentially. And then what they did is that they looked among men with more stressful jobs. So like if you were in the army or particularly within the US Marines, they realized that the men in that unit preferentially had female children because the job was more stressful. So that sort of supported the idea that the X chromosomes were more robust, and that's why the female babies tend to survive better.
Oh, yeah, okay. All right.
Again,
Well,
these are the theories.
theories, yes.
Nothing solid.
Theories. Okay, so neonatal mortality in the Caribbean. So conditions arising in the perinatal period. We have spoken about them. So similar. Notice in the Caribbean, we are similar to globally. So we are seeing prematurity, asphyxia, infections. And then you have things like congenital anomalies and respiratory illness. So, I mean, we mimic, and that's expected to mimic what is global. All right, so neonatal care in the Caribbean, what are some of the things? We went through some of them. Neonatal resuscitation, right? So remember, we are saying that first hour, that golden, we have something that we call the golden hour. That first hour of life is so critical. So you have to be able to, one, pick up babies at risk. So in utero, so that this again is where maternal and child health. Because remember, we spoke about that healthy mother to get the healthy baby. So that monitoring of the mother during labor and delivery, the ability to pick up a baby who is distressed in utero, and to make a decision about what is the safest way to deliver that baby. Is it that we allow mommy to continue in labor and delivery, or is that that's going to put too much stress on the baby, and so we will do a cesarean section, right? Then once that baby is delivered, how was that baby transitioned from in utero to utero, and what are the what supports would that baby require. So neonatal resuscitation, we recognize, is really important, extremely important. You must have persons who can resuscitate a baby. Bag and mass, as I said, not everybody needs to know to be able to intubate. You can keep a baby, you can get, because the single most important thing you can do for a baby when that baby comes out and not breathing is to get oxygen to the lungs, right? Get oxygen to the lungs, get that heart working, get oxygen to the brain. So, and you can do that with bag and mask so you can maintain that baby until someone who can intubate arrives. We know about cord blood screening, right? Particularly in Jamaica, we screen now for our sickle cell disease, right? And that is very important because if you can pick up the babies before they even begin to have symptoms of their disease. So remember, usually the first 2 to 3 months of life, babies who have sickle cell disease do not have complication of their disease. The reason for that is that they have a high level of fetal hemoglobin that is still circulating, right? It's when that fetal hemoglobin begins to be broken down and the sickle cells become predominant that they run into problems. So if we can pick them up from birth, you can begin implementation of certain measures, right, before they even manifest any complications of their disease, right? So you know that they are particularly prone to encapsulated organisms. So, you know, the immunization is very important for these babies. To get the Prevnar vaccine, which the government pays for, for children with sickle cell disease, so they get it free of cost. Get them into either the sickle cell unit or into clinics where they can be monitored, where parents can be taught how to examine for the spleen, taught, you know, all the symptoms, you know, of, you know, anemia, etc., etc. So our cord blood screening is very important. Now, ideally, if you wanted the most out of cord blood screening, every single baby who is born, the parent should be told the sickle status. Unfortunately, because of cost, the only parents who are contacted is if the baby has sickle cell disease. The ideal would be for every person who has the sickle cell trait to know their status, right? So a couple, before they begin to have a family, they know their sickle cell status. They know whether both mother and father has the trait or just one person has the trait, right? Because if just one person has the trait, then the most you can have is a baby who also has a trait. You will not have a baby with sickle cell disease. But if both of you are carrying the trait, then you have a 25% chance at each pregnancy to have a baby with sickle cell disease. So really and truly, we are not utilizing the cord blood screening to the maximum that we could and should, because if we were doing that, I think by now we're beginning to have a generation of people where everybody knows their sickle cell status, right? Now, I'm not saying that in knowing so, it means that you're going to say, well, I have the trait, you have the trait, you know, I'm not going to marry you. That's not what I'm propagating here. I am saying is that people will be going into pregnancy fully aware of what is their risk if both parents have the trait of having a child with sickle cell disease. So that is something to look forward to in the future if we are going to be able to tell, you know, everyone what is their sickle cell status. The Baby Friendly Hospital Initiative, as you know, that was brought in to promote and support exclusive breastfeeding for the first 6 months of life, and then the introduction of complementary feeds and continual breastfeeding up to, it's a woman's decision and choice, up to the age of 2 years. We know that certain baby-friendly hospitals have lost their baby-friendly status, or I shouldn't say lose it. They have not been reaccredited, right? I know it's something that the Ministry of Health and Wellness is looking at, right? But we are saying the baby-friendly hospital initiative is something in the Caribbean we look to, because that nutritional start to the baby and to the child is important. I spoke to you about the neonatal physical exam, that every baby before leaving hospital should have a full physical examination. Special care nurseries, these are areas that are able to take care and offer care to sick newborns. And then, as we say, the neonatal intensive care unit, we are not recommending that every single hospital should have one, but if they don't, there should be the ability to transfer. And then we had spoken about domiciliary visits and the importance of that. But these are the things neonatal care in the Caribbean. Now, looking at Jamaica, just looking at the PROMAC, this is the Program for the Reduction of Maternal and Child Mortality. It was funded by the European Union and managed by the Ministry of Health. And the program was to construct high dependency units at 5 hospitals island-wide. So Bustamante Hospital for Children, Victoria Jubilee, Cornwall Regional, St. Anne's Bay, and Spanish Town hospitals. And I think that all of those have been completed. Mandeville Public Hospital got a neonatal intensive care unit. There was also training in terms of fellowships in neonatology, maternal and fetal medicine, and emergency obstetrics and critical care. And those, although PROMAC, the program itself is over, I know that the fellowships in neonatology and maternal and fetal medicine, these are still ongoing, and they have been taken over by, I think, being run as a fellowship program through the UWI. The objectives of PROMAC was reducing the incidence of neonatal deaths to track due to lack of access, to high dependency care, reducing maternal deaths due to lack of access to emergency obstetric care, and improving the quality of management of high-risk pregnancies at both tertiary and primary healthcare facilities. I'd like to say that, and this is just me saying, I think that it is an opportune time. I think it's needed that in Jamaica we should do another perinatal survey, national perinatal survey. I know that we have started from about 2 or 3 years ago. We have a perinatal national perinatal mortality audit, right? And data is presented, etc. But I think we need to see what is the impact of PROMAC, where are we, what do we need to do? We have to be intentional. If we have to bring down, and I'm sure last year in 2025, you heard that our maternal mortality ratio has increased over the last few years, right? And that is something that the Ministry of Health and Wellness is looking at. But I think we need to have that national survey where we look at, perinatal, what is happening perinatally. And there was also some academic research on the cause and risk factors of premature birth. I know that the study was done. I have not seen any published data, but a study was looking at premature birth was done. So just looking in the Caribbean now, infant mortality
Sorry,
rate.
Dr. Chapman Edwards.
Yes.
Who was this study done by?
This was as part of PROMAC. I know that as part of PROMAC, there was supposed to be a study that looked at the cause and risk factors of premature births, right? I know that and the reason I know is that it did occur is because at the University Hospital of the West Indies, we had data extraction sheets that had to be filled out. So I know that there was data collection. However, I haven't heard about any paper that has been published, or have I seen the results being disseminated at any conference, etc. So I cannot speak to, I don't know if anybody from the Ministry of Health and Wellness is in this class and can speak to it, but I know that there was a study to look at cause and risk factors of premature birth. And on the Ministry of Health website, I don't see anything. When you look on the research, I don't see anything that speaks to this study.
All right, thank you so much.
Yeah, but I mean, y'all can look it up. Y'all can look it up, but I didn't see anything. So again, infant mortality. So remember I said that some of what we did came from that perinatal survey. And also in 1993, I know that I know there was a study looking at, again, the robustness of reporting of infant deaths. So in 1993, only 25% of infant deaths were reported in Jamaica. Right? That means 75%, you didn't know what was happening. Why did they die? Where did they die? Etc., etc. Right? There's been a 50% decline in the past 40 years in the infant mortality rate in the Caribbean. And again, it's mostly due to reduction in the post-neonatal period. Because we point out that the neonatal period still accounts for about 75% of our infant mortality. There are very variable rates between countries, and there's a relationship to socioeconomic status. What are some of the causes of infants? So remember, infant mortality is number of children who die between birth and 1 year. So we're looking at birth and 1 year. So what are some of the causes of mortality and morbidity in the infant period? So conditions originating in the perinatal period. So you have premature infants, right, that cross over. Because some of our tiny babies don't leave hospital until they are 4 months, sometimes 5 months. So they have crossed over into infancy, but they're still having problems from the neonatal period. So the things that cross over definitely are prematurity, asphyxia, babies who, and we now speak about hypoxic ischemic encephalopathy. So complications of babies who have had that goes over into your infant mortality, right? But the other things that we see, acute respiratory illnesses, diarrheal illnesses. Remember, I spoke to you about the impact of oral rehydration fluid, and I'm telling you, it's amazing. If you come in when there's ORF, you will not understand when I say a simple thing like some reconstitution of a packet of salt can make such a big difference in the outcome of babies who had diarrheal illness. Remember, our rotavirus is the most common, right? And what again I saw as an intern, as a resident, the doctors of the day not seeing. I mean, at Bustamante, I know they still have 5 East. The 5 East ward was a ward for infectious diseases. And during GE season, that ward was just filled with babies vomiting and diarrhea, right? I mean, we're not seeing that degree. Yes, we still have gastroenteritis, but certainly not to that degree. And also, once the children get it, the parents understand, get in those oral rehydration fluids. So congenital anomalies, again, that's coming from the neonatal period into infancy, nutritional deficiency, and of course, HIV/AIDS. Okay, what are some of the solutions in the Caribbean? Right, so we look at what we call enhancement of early childhood development. Right, so life experiences. And again, let us look at this post Melissa lens. I mean, it's just coming as I'm going through this. I'm just seeing it, right? So life experiences, sorry, love, warmth, protection, sense of belonging. Think about some of these children who in Western Jamaica, whose their homes have been totally destroyed. They have been living in a shelter, or they are moving from family member place to another, etc., etc. Think about parents who are stressed. I'm stressed because I don't know where the food is coming from. I have no shelter over me. You know, my income stream has been curtailed, right? How am I able? Because I am dealing with my own mental, emotional, psychological distress, right? I need to take care of myself for that. But how am I now able to express these things to my children? The love, the warmth, the protection. We are outside. I saw a family during the night, it's under a piece of tarpaulin, right? The sense of belonging, right? So these are the things we are saying. Interactions. We are speaking about with children in early childhood development, interaction with parents, family members, and adults. And I think sometimes we do not pay enough attention to how do we educate parents? Not because you have a child means you know how to parent, how to interact with those children. I have seen, I mean, every day, just in day to day life, in the supermarket or so, sometimes when I see how the parents are speaking to the little children, you're just horrified. You're just horrified, right? So that interaction, environmental factors. Let's look at this. Propose Melissa, proper nutrition, good health, access to health care, safe water supply, decreased exposure to violence. So you see where all these things are coming in. So first we say enhancement of early childhood development. That's the first solution. Two, investment in early childhood development. You have to invest. You have to put in the money, right? Economic returns, right? If you put in the money in early childhood development, then you have savings later on in for remedial education, healthcare, and rehabilitation. So we need to put in the money. We need to reduce socioeconomic disparities, and I'm sure you all have done the socio environmental aspect to health. Right? So we have to reduce your socioeconomic disparities. We need to reduce gender inequality. And when I speak about gender inequality, right, so typically and usually we are referring to the female gender. But what we have to recognize in today's world, we can also have in a flip gender inequality. And so we must also protect the males who may be suffering from gender inequality. It's a new dimension to when we speak about gender inequality, but we have to recognize in today's world, we can have males who are at risk of gender inequality. And then, of course, improve competencies as adults. Domestic violence, right? This is something we see across the Caribbean, right? And it's something that we say if we want those healthy children, right, we have to look at what's happening in the home in terms of domestic violence, interpersonal violence. So we look at the empowerment of women. We look at our adolescent girls, educating them. We want to decrease our adolescent pregnancy rate, right? Because we recognize that for a lot of females, if you get pregnant early, it really does impact your trajectory, your educational trajectory. Yes, some of them will still go on, and we know we have the Women's Center, but we still have a lot of girls that if they get pregnant early, right? It affects their life trajectory. So we are looking at postponement of pregnancy. We are looking about parental education, about healthcare and development, counseling about conflict resolution, and of course, provision of adequate daycare facilities for young children. Child abuse, we have to look at our psychological, mental health for our children. So we need to educate our population about the conventions for the right of the child, consolidation of programs for early childhood development, improvement in mental health services for children, improvement in social services for children. So again, post Melissa lens. I don't know if you all saw that the opposition spokesperson on education, Damian Crawford, he has been advocating a lot for the early childhood institutions because he said in the thrust to get back schools open and so the ministry has been focusing on your secondary schools, your primary schools, but a lot of the early childhood institutions that were affected, they have not been focused on. And I know he has been advocating for that, but that is definitely something that we have to look at. We can't allow Melissa to derail our early childhood development programs. Remember, for a lot of those children, it's a safe space. It is somewhere where they can get a hot meal, right? It's somewhere where they may get a hug, etc. So we have to look at our early childhood development programs, our mental health services. Post Melissa, I mean, there's going to be such a need, not just in children, but in the adults, in even people who don't live in the Western Jamaica have been adversely affected. So we have to look at our mental health services and, of course, social services. Disability. So this is something where we in the Caribbean, we are behind, right? But we do recognize for child health, disability. So we need to have the early recognition of disabilities. And some disabilities are easier to pick up. So physical disabilities are easier to pick up than your learning disabilities, right? So a lot of children who have learning disabilities go through the system without being picked up. So we need to have early recognition. We need to have your stimulation programs, special education services, whatever physical aids are needed, physical therapy services, speech therapy, occupational therapy services. As you know, we are very short in the public sector for our speech and language pathology, occupational therapy, right? I know that the University of the West Indies is looking at starting a program for to teach your speech and language, your occupational, your behavioral therapists. Remember, we have the autism spectrum disorder that is becoming more prevalent, right? We have need for behavioral therapists. So that is something that we really have to look at. Our ability to pick up learning disabilities. Get in some places, you know, when you send a child for assessment at say like Michael, whatever, they're getting an appointment for 2 years down the line, right? Of course, by that time, the time for intervention, whatever. So we really have to look at how to build our capacity for the early recognition, for training our teachers in dealing with children with learning disabilities. In terms of nutritional disorders, promotion of breastfeeding, as we had spoken for, establishing of your baby-friendly hospital initiative, education about diet and nutrition, monitoring of growth at clinics and school. Remember I said, when I was a resident, and so it was under nutrition, it was your kwashiorkor and your marasmus, etc. We're not seeing that to that extent, but what we are seeing now is the overnutrition. Those children who are not exercising, who are on their devices, excessive screen time, eating of highly processed foods, the snacks, the whatever. Our education now has to be not just about undernutrition, but overnutrition. We have to look, I know the ministry has started, but we have to look at what is available in our schools for the children. The sweet sugary drinks, right? The highly processed snacks, the salty, the salty chips that the children all love, the oily, salty and oily. So education about that and nutrition, monitoring of your growth and that promotion of healthy lifestyles, physical education in the schools, right? Etc. So promote a diet sufficient in calories for normal growth, low in saturated fat and cholesterol, rich in unsaturated fat, your omega-3 fatty acids, low in added salt and sugar, high in fiber content. We are reducing dietary fat intake, less than 30% of your total calories, cholesterol intake, less than 200 milligrams daily. And this restriction really would have no adverse effect on growth, neurological development, and metabolic function or nutrient adequacy. Fruits and vegetables, whole grains, low fat and non-fat dairy products, beans, 2 servings of fish per week, lean meat. So we need to be educating our population, regular physical activity. For infants and toddlers, right? And this is something that parents are quite surprised when you say, I remember infants are less than 1 year, right? And your toddlers. So we say no sweetened beverages, no fruit juice, right? No fried foods, no baked desserts. Parental control is key, right? Parents should choose meal times, promote social interaction. So it shouldn't be the children sitting in front of the TV and eating, right? We should have well-defined meal time. You come today. Now, guys, I know how difficult this could be in this life because with both parents working, children having a different, sometimes the children are coming home before the parents, etc., etc. But we should try to have that meal time to promote that social interaction. We are sitting at a table, we are eating, right? We're going to act as role models for eating behaviors. So parents are going to be eating the vegetables, having the portion sizes, etc. Right? Limit video and TV watching less than 2 hours per day. In terms of Caribbean solutions, we do have some micronutrients where we may have fortification of wheat and corn with iron and folic acid. And this is now a public policy in about 22 countries in Latin America and the Caribbean region. Management guidelines. So remember, we're saying there are things, the respiratory illness, the diarrheal illness, etc. So as the Caribbean, we have come up through WHO, through CARFA, through the Ministry of Health with guidelines. So we have guidelines, WHO guidelines for the management of acute diarrheal illnesses, acute respiratory illnesses. We have Caribbean guidelines, right, for asthma management and prevention. We have Jamaica Ministry of Health has guidelines for several of the childhood diseases. There's a maternal care in pregnancy guidelines for the Caribbean. That's through CARFA, right? In terms of HIV/AIDS, provision of ARV therapy, right? And we know that that is something that we have in the Caribbean. And we now have, medications to be taken immediately after you may, post-coital, if you think you may have been you did some risky, so we are looking at that. HIV and AIDS, education, right? Can't say any more about that. Education. We must educate about sexual practices, sexually transmitted infection, counseling about lifestyle, prevention of maternal to child health transmission. And we have eliminated that in Jamaica through the Jamaica Pediatric AIDS, Prof. Christie and her group, right? improvement in availability of antiretroviral drugs, change in attitudes to HIV-infected persons. And of course, we have new things, the ability to test, rapid tests that you can do at home, etc. So prevention of HIV infection among prospective parents, avoidance of unwanted pregnancies among HIV positive women, prevention of transmission, right? So during pregnancy, labor, delivery, and of course, we do not advocate for breastfeeding. We provide the mothers with formula. And again, financing. So I want to quickly go to the well baby care, right? Because this is the hallmark of what we do in pediatrics. The hallmark, right? So well baby care is where children or parents, mothers are asked to bring their babies routinely to clinic. The baby is not ill. So this again is where health literacy comes in, because we are saying to mothers, listen, we need to monitor the growth of the baby, monitor nutrition, monitor psychomotor development. So the babies come to us. Ideally, we should see if the baby is discharged early from hospital. That baby should be reviewed at least at a week. Some people say 3 days, right? But certainly within that first week, right? So they come at a week, then they come at 6 weeks, 3 months, 6 months, 9 months, 12 months, 15 months, 18 months, 2 years, right? Those are the routine up to 2 years. And then we really and truly should see them again at 4 years, right? And ideally, you really should be seeing them yearly up until adolescent period, where again now you start during adolescence, you should see them every 6 months, right? But certainly up to the 2 years, that is something that we see in our clinics, right? So we have monitoring of growth, nutrition, and psychomotor development. We can do anticipatory guidance, right? About nutrition, about behavior, about parenting. We do our immunization, right? And we can identification of high-risk infants, like your low birth weight infants, neonatal jaundice, your asphyxia. Okay, if we look at the immunization coverage, so let me see if I have a slide. Okay, so the expanded program of immunization for Jamaica, and I did not add at birth. So at birth you get BCG, but we are also now giving your hepatitis, the first
Hep B.
hepatitis. Yes? Somebody was saying something?
I was just saying Hep B.
Oh, yes,
That's
Hep B
it.
at birth. Thank you. So that is at birth. Then at 6 weeks, we give the first pentavalent. And the pentavalent has your DPT, OPV. It has so DPT is diphtheria, pertussis, and tetanus. OPV, in fact, no, we do IPV now. We now do IPV, which is the injectable polio vaccine. We do it at 6 weeks and we do it at 6 months. Right? So we no longer give the OPV at 6 weeks and at 6 months, we do the injectable polio vaccine. So at 6 weeks, they get the pentavalent, which is DPT. It has the DPT, it has the Hib, Haemophilus influenza type B. It has the hepatitis, and we give the IPV. So they'll get that at 6 weeks. At 3 months, they will get the pentavalent again with the OPV instead of the IPV. Then at 6 months, they get the third pentavalent. At 1 year, we give them the MMR, measles, mumps, and rubella. At 18 months, they get a DPT and DPT OPV booster and an MMR booster. And then at 4 years, you get a DPT polio booster again. So that is, now there are some other vaccines that are available that are not on the expanded program of immunization, but the Ministry of Health does say, if you can afford to give it to the infants, you must do so. As we had mentioned before, there are certain babies, the children with sickle cell disease, Down syndrome, those two for sure. Um, through the Ministry of Health and Wellness, you will get your Prevnar, which is your pneumococcal vaccine. And they get that at 2, 4, 6 months and at 15 months. So just looking at immunization coverage, because remember we were saying that this is something that we have to look at, and we really want coverage above 90%. And the closer to 99% you are, the better. Now, these are some old figures. I think I have newer figures. Let's look for Jamaica. The newer figures, this was 2018. I was looking up to see, oh, I have 2023 too. Let's look at the 2023. And as you see here, this is really great coverage. BCG 99, the third DPT polio 99%, third Hep 99, Hep B, the third Hep B 99%. The first MMR, which is at 1 year, we have 92%, and MMR2 89%. And as I mentioned before, that MMR2 used to be given at 4 to 6 months, but because of very, very low coverage, it was brought to 18 months when the children are still being routinely seen in the clinic. But I mean, these are great immunization rates. We have to look to see. I know that during COVID, this was done after COVID, this to see how we were doing, but we also now have to look at post-Melissa to make sure that we are keeping up our coverage. Okay, so here we are, post food for thought, post-COVID, and I've now put post-Hurricane Melissa in Jamaica. How did I, right. Mental health, learning loss, violence and antisocial behaviors. Remember when the children came back to school post-COVID, we were seeing violence and antisocial behaviors. Certainly post-Melissa, anxiety disorders, depression, right? And substance abuse. So, solutions, as we have said, the most basic but important practices identified include skill attendance at delivery and newborn care of low birth weight infants, hygiene promotion, prevention of mother-to-child transmission of HIV, and pediatric treatment of AIDS, adequate nutrition, particularly in the form of early and exclusive breastfeeding during the first 6 months of life, complementary feeding combined with continued breastfeeding for at least 2 more years, micronutrient supplementation to boost immune systems, immunization to protect children against the 6 major vaccine preventable diseases, use of oral rehydration therapy and zinc to combat diarrheal diseases, judicious use of antibiotics to fight pneumonia, and then, of course, our mosquito, the vector prevention, right? Effective prevention for your dengue, your chikungunya, your Zika, your malaria, your, adequate prevention. So in conclusion, saving the lives of mothers and children by providing universal coverage of essential intervention throughout the life cycle is a fundamental objective of the continuum of maternal, newborn, and child health care. And that's it. Any questions?
I have a question. This is the increase in the time for review of adolescents. So you're saying that they would be seen every 6 months?
So ideally, I'm giving you ideal. I know it doesn't happen. So ideally what we should have, I gave you the time slots up to 2 years, right? Ideally, it doesn't happen, but we really should review those children yearly until they are at 4 years, right? We really, but that doesn't happen. They tend to come back for that 4-year booster. Then after 4 years, ideally, it doesn't happen. It happens, let me retract. it happens in the private sector. So children who are seen by pediatricians will follow this. But a lot of the clinics, children only present to clinic if they are having an intercurrent illness. But really and truly, you should be doing a yearly follow-up of these children, looking at growth, looking at development, looking at school achievement, all those sort of things. So we say you should do yearly between that 4 to 6. That after that booster, we should see them yearly until they reach the teen. So we're looking at 12, let us say preteen 12, 13, because then now you need to see them because we need to monitor and counsel, and so because they are now going through puberty. So pubertal changes, looking at their nutrition, making sure that, no eating disorders, there's no bullying going on, there's no, what is the sexual, what is happening sexually, any drinking, so we are in the adolescent period, we should really be seeing them every 6 months. Because remember, we're looking at the rapid periods of growth. So 0 to 2, you have rapid changes, right, in growth. And then the next period where you have the rapid set of changes in terms of physical, emotional, everything, is that adolescent period. So we really should be seeing adolescents every 6 months. But it doesn't happen, but we really should be seeing them because there are so many changes. They are moving from primary school to secondary school. They're becoming aware of their body image, right? They're the signs of puberty. So the girls are growing breasts, they're starting their menses, you're starting having body odor. The boys, body odor, change in voice, you're having the acne, you're having them having to interact with a new set, making new friend groups, right? Then you have peer pressure. There's extreme peer pressure. Adolescents listen to each other and they're not listening to the parents, etc. Right? Then you have, the experimentation, drugs, alcohol, tobacco, sex. Here's where you have to get in your education about STIs, etc., etc. So during the adolescent period, we really should be seeing them.
Okay, thank you.
Just to add, Dr. Chapman,
Yes.
that between 2 and 6, our babies in our area, we see them every 6 months.
Okay, great. Great. And that is what's supposed to be happening. Any other questions or any other things to add to what I've said? Because I hope I've been able to bring across to you what child health, what it encompasses, and it's many different areas. And I didn't mention here, but part of child health, and we do refer them, is remember dentists. They really should have their first visit to the dentist at about 18 months to get used to the dentist. And they should be having, just how we say well baby care, they should be having that well dental care. So every 6 months, the cleaning, etc., etc. So we do recommend and advise our patients that they need to be going to the dentist. And certainly when we see them, if we pick up any dental caries or that sort of thing, we will refer. So it's really a multidisciplinary thing if you see, because there are so many areas that need to be monitored, right? Any other questions, clarifications? If not, I hope I've been able to bring across to you what we do in pediatrics, why we do it, and the importance of doing it, and that it is really part of that continuum, right? So if at the end of the day, from a government point of view, they want a healthy workforce, if you want that, you really have to start. And as I said, it's a continuum. The woman has to go into pregnancy in her best health. For a woman to go into pregnancy in her best health, she has to be in her best health during the adolescent period. For an adolescent female to be in the best health, she has to go into adolescence from a healthy childhood period. For a healthy childhood period, you have to come out of the neonatal. So you have to have a healthy neonatal period. And to have a healthy neonatal period, you have to have a healthy mother. So it's a continuum, right? And it's an interplay. And we have to intervene at all levels if for your end result. So if there are any no more questions, I'd like to thank you. Thank you for listening to me over
There was
the.
a comment in the chat, Doctor.
Oh, sorry. Our creation is easier and cheaper now. Oh, it did.
Sure.
I think I missed. Let me go to it. Okay. If I'm able to share the lecture, they're supposed to have given it to you already. They did not give you the handout. Somebody said just check in if you are able to share the lecture. But the handouts is available in the office. They were supposed to make copies and circulate. Okay? You have you gotten a
Thank
handout
you.
or
We'll
not?
double check.
Double check for me. Double check, and if they don't have it, let them call me. But they have a copy of it that they usually print and circulate. And they have it, as far as I'm concerned, they have it soft copy too. They have a copy of my lecture. Okay. Can't ask for Dr. Trotman. The cost to contact mothers with their children is more feasible now given the advent of AI. Yes, but the only thing with that, I guess you now have to look at data protection. How does that fit in with the data protection? Because heaven forbid, should a mistake be made, that you contact a parent advising them of the sickle status and it's not the correct parent. So yes, I agree with you that there is a feasibility, but we have to look at how we can do it, data protection, etc.
I agree, but I still think that should be brought into the conversation and we shouldn't just stop at, oh, the cost isn't feasible. I feel like it's something we can look at now.
Yes, well, I'm agreeing with you. I'm just saying you have to put in the guardrails.
Yeah.
I agree with you. In fact, it should be something possibly where, because you know how sometimes with something you have to log in to get a particular result or whatever. So it could be something like that. I don't know, but I agree with you.
I'm wondering, Dr. Chapman, if when the parents, because they routinely come at least up to 1 year, I'm wondering if the results are available in time. If at the postnatal clinics, at the well baby clinics, if they won't be able to get a status card, even if the status card says negative, for sickle cell, if they could get it at that time. I guess maybe the printing cost of the status card, or maybe there's a section in the passport that could say this is your result. Maybe it could go there when the public health the MOH is in the health department gets it, so that they can at least know that they're negative. I don't know. I mean, they revised the book of recent, but I'm not sure if that was included in the book.
No, it's not. It isn't. All that's in the book is to tick whether the baby was screened or not. So there's somewhere for you to put cord blood screening done, right? But it doesn't have, because at the time the baby's leaving the hospital, you would not have the result, right? But as I said, when I asked about it, I was told it is really a pure dollars and cents sort of thing. But as you say, now that we have, cheaper ways maybe of being able to deliver those results, there is something the ministry should look at again. Because really and truly, I mean, you screen them and you know the results. It's just a matter that you have not disseminated the results. You only disseminate the positive results.
Yes, and it's the same thing with cervical cancer. I mean, you get all these results and you only call the ones that are abnormal because they say you're using CUS. But if a woman comes to do her pap smear, she should know that it's
Of
normal.
course.
Because
Of course.
no, because what is happening in my parish now,
we're advocating for them to call all persons. So as the woman hear a call for pap smear, she start fretting because she said she never get call yet. So it must be that it's bad.
Of
It shouldn't be
course.
the case. All persons should know their result.
Because then you're sort of limiting the scope of screening. You know, you're limiting the scope of the screening because if we were doing that from the time they start screening, a lot of people in Jamaica will know their sickle cell status. And there's so many people who are walking around and, they say, oh, no, I don't have sickle cell. But they don't understand the trait. You don't have any signs. You don't have any symptoms. And it's when they get, and it is so devastating sometimes because I worked in sickle cell for a period of time. And when you have to counsel these parents who are coming in, sometimes it's their first pregnancy or whatever, and they are just shocked beyond, whereas this is something that everybody should know. Yes, I have sickle cell trait. Okay, I meet this guy and he has it. Okay, we can make an informed decision. Am I going to have children? You understand? That's all we are saying. We are not saying that you're going to say, well, I'm not going to marry this man because he have the trait. No, that's not what we're advocating. But we are saying a married couple can make an informed decision. And they are not, faced with it at the time when the child is ill and you are giving them that sort of news. And I mean, we have been screening long enough in Jamaica where this should not be happening. But that's why you all are doing the Masters of Public Health. So when you go back, you all are going to advocate. Advocate, advocate, advocate. Okay, any further comments or questions? If not, I'd like to thank you. Thank you all for coming to the lecture, listening.
Thank you as well, Doctor. Very informative.
Edward.
Okay then. All right. Have a good day.
Thank you, Prof.
Bye.